Hello, this is a quick video about depression. Depression, which is usually characterized by mood disturbance like low mood, apathy, um, insomnia, which difficulty falling asleep or waking up early, anorexia, losing pleasure in activities that the person used to love. It's also associated with chronic disease, people with diabetes, dementia, Parkinson's disease. Anyone who has long-term condition is more likely to be depressed. There's association. Depression is also associated with high suicide rate, neglect of dependent children or partners. It's also associated with early death, alcohol abuse, or abuse of substances. So the person who is depressed might start binging on alcohol, or they might start using illegal substance, or the person who's using the illegal substance or alcoholism might get depressed. So it's two-way street. Antidepressants are usually used in moderate to severe depression. In mild depression, it's usually recommended to use cognitive behavioral therapies. And as we see, there are several classes of antidepressants like tricyclic antidepressants, selective serotonin reuptake inhibitors, selective um, norepinephrine reuptake inhibitors, tricyclic antidepressants, as we said, um, tricyclic related antidepressants, selective noradrenaline reuptake inhibitors like reboxetine, and so on. So basically, there's no first and second line choices. It depends on comorbidities and the patient's characteristics. But usually, the selective serotonin reuptake inhibitors are used first because of the low risk of overdosage and low side effects, unlike tricyclic antidepressants, which are usually associated with high risk of toxicity and a lot of antimuscarinic side effects. Um, the safest is thought to be sertraline, is usually used for patients with myocardial infarction and angina. And also, second line choices include the monoamine oxidase inhibitor moclobemide and reboxetine and lofepromine. But basically, this SSRIs are used first. Um, and then if someone is using antidepressants, it's very important that they do not use two antidepressants together, like especially monoamine oxidase inhibitor, which is very dangerous if you use with other um, antidepressants to cause serotonin syndrome, um, which is usually toxicity that's caused by too much serotonin in the synaptic gap. And symptoms include agitation, tremor, myoclonus, and hyperthermia, which is very dangerous. Also, if someone is taking monoamine oxidase inhibitors, he needs to wait for 1 week or 2 weeks, depending on the specific drug, so that you don't have too much neurotransmitter um, in there and not to cause serotonin syndrome. So you wait for 2 or 3 weeks after you take your last monoamine oxidase inhibitor, or if you are taking tricyclic antidepressant or selective serotonin reuptake inhibitor, you wait 2 weeks or 1 week depending on the specific drug before you start monoamine oxidase inhibitor. So this is the washout period. It's the period between taking monoamine oxidase inhibitor and other antidepressants like TCAs and SSRIs. Also, antidepressants are associated with aggression and anxiety. So you see, if someone is taking SSRIs in the first few weeks, they become very irritable, aggressive, shouting at people. So you need to look out for those symptoms and make sure that the dose is either reduced or they are referred to their doctors or to their um, family members. Also, St. John's wort, which a herbal which is used in for mild depression, should not be used with antidepressants because of the risk of serotonin syndrome. Because St. John's wort is thought to inhibit the reuptake of serotonin. So if you give St. John's wort with either tricyclic antidepressant or SSRIs or monoamine oxidase inhibitors, this will increase the concentration of serotonin, resulting in serotonin syndrome and toxicity. Also, look out for um, self-harm, as you can see in this picture, people who self-harm or with paraphernalia, um, with someone trying to harm themselves. So people need to look out for those. And also, there's a confusion caused by tricycle antidepressants and SSRIs and all antidepressants. So you need to look out for those as well. Um, and if we look at some cautions for the classes of drugs, for tricyclic antidepressants, usually antimuscarinic side effects like um, angle closure glaucoma, which is rare. It's also a benign prostatic hyperplasia for with men. Also, dry mouth, constipation, basically the antimuscarinic side effects, and also hepatic side effects for trazodone, and also, tricyclic antidepressants are best avoided in someone with cardiovascular disease because they cause changes in the ECG, causing a long QRS complex or long QT interval. And they're also very toxic in overdosage. SSRIs are usually safe and with less side effects, unlike TCAs, but citalopram and citalopram are associated with long QT intervals. Also, they increase the bleeding time, so they should not be used ideally with antiplatelets and anticoagulants, but they're usually used if needed. But you need to be aware of the problem with bleeding. Also, GI and some CNS side effects. Monoamine oxidase inhibitors have dangerous interaction with some foods like tyramine, for example, mature cheese like Stilton or soybean extract, and others like mirtazapine, duloxetine, and venlafaxine. Uh, Duloxetine and venlafaxine also associated with bleeding like SSRIs, but also cause some antimuscarinic like symptoms for mirtazapine, drowsiness, and weight gain. So, as we said, do not give antidepressants with monoamine oxidase inhibitors. Also, it's very important that if someone is taking antidepressant, you should not sell them. The OTC decongestants like oxymetazoline, pseudoephedrine for colds and sinusitis. Also, somatropitant is basically used for migraines. This could also be sold over the counter. It increases the concentration of serotonin. Remember, this is 5-HT1 agonist, so it it could result in serotonin syndrome. Also, tramadol is thought to be weak um, norepinephrine and serotonin inhibitor because of the risk of serotonin syndrome again. And look for, as we said, increased aggression and suicide. Do not use St. John's wort. And also, it's very important that all antidepressants are not withdrawn suddenly, and those to be titrated down slowly. And then, if you are switching to antidepressant to cross taper, which basically means you reduce the dose of one drug while simultaneously starting the other drug. So you need to look for the protocol to follow, otherwise you risk serotonin syndrome. For drug interactions, remember there's long QT interval, a prolongation by stylopram and tricyclic antidepressants. So do not use two drugs which prolong the QT interval because of the risk of torsade de Pointet and ventricular fibrillation and sudden death. So, tricyclic antidepressants, macrolides like erythromycin, citalopram, antipsychotics like pimoside, haloperidol, all of them cause QT interval prolongation. Antiarrhythmic drugs like drondrone, amiodarone, sotalol, and so on. Also, antimalarials, especially the new ones, chloroquine, quinine, they all cause QT interval prolongation. Also, mesalastine and moxifloxacin, the quinolone. So, and SSRIs, as we mentioned previously, they cause bleeding, so you need to better avoid these ones. And also, any drug which increases the concentration of norepinephrine, serotonin, dopamine, because of the risk of serotonin syndrome. And also, remember fluoxetine and paroxetine as enzyme, I think CYP2D6, so they increase the concentration of some antiepileptics. And tricyclic antidepressants avoid antimuscarinic drugs like antihistamines, antipsychotics because of the severe antimuscarinic side effects like difficulty urinating or the rare side effect of angle closure glaucoma. And antiarrhythmics like drondrone or sotalol, alcohol which causes sedation, antiepileptics which also Um, it's also reduced by anti-epileptics, which are enzyme inducers like carbamazepine or phenobarbital or primidone or phenytoin. Um, and for mirtazapine, people should not take with alcohol or benzodiazepine and sedatives. And reboxetine do not use with macrolides like erythromycin or clarithromycin because of the risk of increased concentration and the risk of more side effects. And as we said, we repeat again, do not give antidepressants with monoamine oxidase inhibitors because of the risk of serotonin syndrome.